Good evening, cataract surgeons. How are you doing? I hope you're doing great. I decided to make you this video, and I will name my different techniques of doing capsular Rhexis. So this is the most famous capsular Rhexis technique that is done by most cataract surgeons, especially the beginner surgeons, which involves the cystotome and the rotatus forceps. First, after making the paracentesis and the main wound, filling up the chamber with the good viscoelastic, either Helon or Viscot. Dispersive or cohesive, it doesn't matter. Me personally, I prefer the dispersive because it gives the AC a better stability. However, it's more difficult to aspirate at the end. Anyway, let's go in and see. Going on our first, I made the cystotome and going in with the cystotome and create a central neck and create a flap. Now you want to run it around 2.5 millimeters, so half diameter, and then flip it over slightly, and maybe you can lead it around 2-3 clock hours. That is totally fine. And then conventionally, even especially if you are resident training, you would always make sure that you are filling the AC with more viscoelastic and leading the flap edge to the direction you desire. So here we filled up with more viscoelastic. The supervisor is telling me where to run the flap. He wants me to run it inferior in the screen and then towards the main wound, using the forceps and running smoothly. Here you can notice, as a beginner surgeon, I'm losing the viscoelastic from the AC, but regardless of that, I am pretty able to almost complete the Rhexis, filling up more viscoelastic and then going back with the forceps to complete the Rhexis. So this is pretty conventional and very famous technique, using two instruments to complete the Rhexis. I recommend that you always start with this technique because it's the easiest and the safest. Now when you level up, I think it is important that you change some technique or you learn more techniques from different surgeons. The advantage of being a surgeon under training, that you get the exposure to of working with different people, and in my opinion, make every surgery count. Meaning, in every surgery, make it a goal that you learn something new. So in this case, I decided to learn in the surgery a different technique used by a different surgeon. And I told him, sir, I am really used to doing the two instrument technique, but I want to learn your technique because I am under training and you're a good teacher, so let me learn from you. He said, no problem, let's try it for the first time, but be very careful and do exactly what I'm telling you to do. So here, instead of going with the main wound, I am doing a different approach. I'm going from the paracentesis here, making the 26 needle gauge to create a cystotome, and going from the side port, after making sure that the AC is fully inflated with the viscoelastic, creating the central neck as we observed earlier, and leading it around mainly from the paracentesis. You don't really need to go from the main wound. As long as your chamber is full of viscoelastic, you will not lose this Rhexis. It is important to notice that your needle should be very close to the Rhexis edge and should not exceed 1 millimeter away from the area you are running it at or you are leading at. So you basically need a needle and good fixation. So I'm using the other hand of another forceps to secure the globe and then run the flap 360 degrees. The reason that you should learn all of these techniques, because you really never know what you're gonna face in the future. You're gonna face trauma cases. You're gonna face cases where you cannot use the main wound as a good entry for your Rhexis. If you have a shallow AC, if you have intumescent cataract, so different scenarios. And best advice is learn all the techniques available on the table, and you pick up whatever suits you in the future, and you tailor your technique according to each patient. So that is done. Now at the very last step, I just wanted to remove the flap with the forceps, and that was completed nicely. Now the third way of doing capsule Rhexis is using the plain forceps. Let me show you how I do this. So again, after like vision blue and conventional 2 paracentesis and main wound, I'm not gonna use I'm not gonna use the needle or the cystotome. I'm gonna go ahead and use the blunt forceps in this case to go in, puncture the capsule, create a flap, and run it 360 degrees without using any further instruments. I'm gonna use the 0.1 forceps here to secure the globe, and going in with the Otrata forceps, the lips are closed, embedded it like inside the capsule, created a small flap, and I'm gonna run it now. I will lead a little bit, like few clock hours, towards the periphery, then hold it close to the base, and slowly run it like all the way to the desired position. Again, the best for your patient is using the technique that you are most comfortable with. However, I think you should be equally comfortable. You should come to the point that after training, to the point that you are equally comfortable using all these techniques whenever you desire. There is no one technique better than the other. You decide when it's better than the other according to the case, according to the difficulty, according to the severity, and according to the AC depth. Now, like after filling up more viscoelastic, I'm running the flap, and the supervisor is just leading me and helping me with the directions, where to bring it and when not to bring it, and where to avoid the extension. I'm very grateful to have a very good supervisor who taught me all these. So should you. Okay, these are the main techniques that I'm using in creating the Rhexis in my cases. I hope you found this helpful. Let me know how it works for you. Thank you.